Introduction. 1. The phrase acute chest pain, ACP, is commonly used in emergency medicine. It refers to sudden onset of severe chest pain, which causes distress to the patient. It is important to start the diagnosis and treatment of the case simultaneously, and therefore, one must know the various important causes of chest pain. 2. Assessment of patient, careful history and general condition, vitals, can give clue of reason for chest pain. Diagnostic feature of common causes of chest pain are given in Apex A of this chapter. 4. Management. A. Vitals to be recorded, pulse BP, respiratory rate. B. Careful history and examine of the patient. C. ECG. D. X-ray chest. E. TLC, DLC sputum for Mycobacterium tuberculosis. F. Biochemical. 5. Medical management depends on diagnosis. A. General management. I. Bed rest. I. ABC, II, IV line, oxygen, IV, antiemetics, analgesics, broad spectrum, antibiotic, V. Specific treatment depends upon the cause of chest pain, VI. Prepare patient for angiography, ischemic heart disease, IHD. Introduction. 6. IHD may be due to formation of thrombus, which occludes coronary artery, or due to spasm of the artery. A. Symptoms. Chest pain of cardiac origin is of sudden onset constricting or crushing, located in the retrosternal region, and may radiate to neck, jaw, or upper arm. It may or may not be associated with profuse sweating, nausea, vomiting, syncope, or an impending sense of doom. The pain of angina is worsened by exertion and relieved by rest. However, the pain of myocardial infarction may not be relieved by rest. B. Assessment of the risk factors is important when dealing with a case of IHD. The following modifiable and non-modifiable risk factors should be looked for. I. Non-modifiable risk factors. I. Age anked, 35 years. I. Sex male anked, female. I. Family history, IV. Ethnicity. I. Modifiable risk factors. I. Smoking. I. Sedentary lifestyle. II. Obesity. IV. Hyperlipidemia. V. Mental stress, VI. Hypertension, VI. Diabetes, mellitus, III. The patient should be asked to lie down on the bed. In case he is uncomfortable in the lying position, he should be propped up. Further action as follows should be taken. I. Start oxygen via nasal catheter or mask. II. Start a V lifeline with 5% dextrose normal saline, II. Monitor pulse BP, respiratory rate, and temperature, IV. Give half tab Disprin and a tab of statin, Atorvus, or 300 milliliters of tab clopidogrel, V. Record ECG. VI. Tablet, sorbitrate, can be given sublingually. One tablet is given to be kept under the tongue until relief of pain occurs or until headache develops. VI. Check cardiac tray and keep all drugs ready for use. Symptoms: common diseases, presenting with acute chest pain, angina, myocardial infarction, pneumonitis, pneumothorax, esophagitis, AMP, gastritis, chest pain, retro. Sternal constricting subsides on resting. Retrosternal constricting may not subside with rest, varies with breathing sharp, stabbing epigastric, radiating localized, radiating to back, let arm and jaw, radiating to back, and amp. Let arm and amp, jaw, increases on full inspiration, usually unilateral, localized relief from pain, relief on rest and amp, sublingual, nitrates. No relief on rest and amp, sublingual, nitrates. Sometime positional change relieves pain. Water seal, drainage will give relief. Relieves or aggravate with food. History HO, chest discomfort on exertion at stress. Family or past HOID, cardiac risk factors, favorico difficulty in breathing, no relevant past history gastritis, associated symptoms, nausea, hypotension, profuse, sweating, nausea, vomiting, nampi, profuse, sweating, hypertension, dyspnoea, sputum, hemoptysis, dyspnoea, vomitus containing ingested food, hematemesis,